Right. Thank you for inviting me to present this. Present today percutaneous approach to subaortic membrane. So Dr. N, who is a medical doctor, she's 69 years old lady. She presented to my clinic as a case of severe aortic stenosis. She had been diagnosed with a severe aortic stenosis as part of her pre-op assessment, as she had also been diagnosed recently with a breast CA. And she's been deemed to be for mastectomy and locally invasive disease. She does also have a past medical history of hypertension, diabetes, and she's CKD with a creatinine of 250. And she does have also previous COVID with residual lung fibrosis. Her echo showed the following. This is still images since those being from different hospitals. Showed very thick LV. The aortic valve is quite thickened. And there is a moderate MR and severe S with a gradient of 41 and pressure half time of 365. There is also high probability of pulmonary hypertension with TR measured at 76 and IVC was not collapsible. So the report from the other hospital was severe aortic stenosis. There is moderate to severe aortic regurg. There is subaortic membrane was seen. And there is normal EF with RV being dilated, however normal in function, and there is high probability of pulmonary hypertension. So anesthesia pre-op for the breast CA said, no, you will not go for a breast surgery. You need to fix the pulmonary stenosis as well as you have pulmonary hypertension, which will make you a difficult case. So they referred her back to cardiology. Cardiology looked at the case and said, declined from cardiology point of view, sent to cardiac surgery, and cardiac surgery reluctantly. So the patient was obese, high BMI, and CKD with a creatinine 250. He was reluctant to do the case, and patient reached my doorstep from other hospital. So, and she was in a dilemma where CV surgeon is sending back to cardiology. Cardiology was sending back to the CV surgery. She was stuck with her breast CA and she's getting anxious that it's getting to spread out. It's locally invasive now, but still under control. So we decided, we didn't know what to do in the beginning, to be honest. So we started with the TE because we wanted to visualize the subaortic membrane in a better way, as well as to see if TE views will guide us the procedure later on. So very thickened valve, as you can see. And you can see also there is both aortic stenosis and aortic regurg, better visualized in this image, where you can see there is some, you can maybe visualize now the subaortic membrane in this view. This is the subaortic membrane clearly seen in the LVOT area. And this is a 3D image of the subaortic membrane as well. Not the best image, but it's there. So we also measured, which is later on we will show that was not accurate, the distance between the subaortic membrane to the valve itself. It's measured in the echo to be 0.9 and 1 centimeter. This has kept me puzzled. This is not doable if it's that deep, and I was going through all the companies and thinking which valve we could use. The area, because the patient also had a CKD, we were thinking what we should do, and we also wanted to tell the surgeon if the patient was pushed toward the surgeon what kind of valve he should be using. The area was measured around 3 centimeter, so also very small valve, and her BMI was high, so she will end up needing high-risk procedure with a small annulus, would require annular enlargement, subaortic membrane resection, and the valve replacement. Plus minus also CABG because we didn't by now have any coronary angiogram as well. So the surgeon again was reluctant. Anesthesia, high PA pressure with a normal RV, not a contraindication, but she might end up difficult to wean. So he was reluctant. The patient herself, being a doctor and hearing all this controversy, was very reluctant and very scared. And she told me, keep me away from the surgery as much as possible. So with a very high risk consent, we went for a CT, given her creatinine is 250. We ended up getting an area very similar to what we got in the TE, an area of 286, very small annulus. The sinuses were spacious, 27, 27.7, and 29. and the STJ was also spacious comparing to the annulus. Coronaries were not an issue. Height, it's 11 in the right, but STJ and the sinuses were quite spacious. Now, this is where the membrane lies. It's in the stretched view of the 3 meniscus, end up at 5.3. And if you take the regular view, it's 4.4, just below the annulus. So it's could be covered with a long valve, a self-expandable valve. This is how much calcification we had. So we had a total Gaston score of 900, where the total calcium was only 700, so it's not very calcified valve as well. And this is how, when we go down from the annulus down, you can see the sub-aortic membrane extending up to around 5.8, 5.6 millimeter under the valve. So the only easy part of this case was access, to be honest. There was no problem with access at all. So the challenging for this cases were CKD, creatinine 250, and there is a lot of social economic thing as well. The patient is non-Kuwaiti, and needing the hemodialysis in Kuwait for non-Kuwaitis is quite difficult. So she really did not want to go into dialysis. She does have low calcium, and we had also to think about ability to cover the membrane and to keep it covered during the case and after the case. And then there was also possibility of suicidal ventricle. The ventricle is quite thick. And she would require TE, but we cannot intubate the patient. So we would have to do TE in and out during the procedure while the patient is laying down the table. So we planned for transfemoral approach, and we decided to go for size 26 evolute FX. Wow. This is an oversize of 32%. And we also went into TE guidance and conscious sedation and use very minimal contrast. Her coronaries, fortunately, did not show much of disease. There is some mild disease. This is 2cc picture of the left and right. And as you can see here, this is with the Safari in, and this is a small Safari. You can see the pre-shape being squished with every beat, tell you how big is how stiff is the ventricle and how big it is. This is the subaortic membrane saying hi to us during the procedure, and this is the best view where you can see the subaortic membrane, and we decided we're going to use this view for deploying our valve. This is the AI and aortic stenosis, and we started deploying me and Abdullah the case. The case was paced. Fortunately, Abdullah could not resist giving some injection from time to time, and this is an ongoing fight between us. And we start under pacing to deploy the valve, and then we pushed the valve even further. Just here we didn't like the depth, so we pushed even further, and then we start opening the valve. We thought at this height, this is going to be hopefully good. And after that, why the valve in there, and this is the beauty of self-expandable valve as well, and especially in this case, we could keep the valve there, not release, and look at the TE and see that we achieved actually covering of the subaortic membrane by transesophageal echo. We were happy with that. We took our picture, we took the gradient, we checked for AI, we saw if there is any paravalvular leak. We were happy, then and we are covering just the subaortic area and not intruding into the mitral area and not causing any MR. We released the valve, and you can see it's a bit constraight, but it's 32% oversized valve. The gradient after the valve was released was 5.8. And there is the valve was in place, and this is transthoracic inside the room, and you can see there is a kissing LV, almost threatening for suicidal ventricle. There was no paravalvular leak, so we did not take a final shot post-release. Gradient inside the room. I think that the echocardiogram guy was trying to punish us, Al-Ahmadan. He gave us the highest gradient he could by over marking the measurement, but it's 13.2. And we were happy with the result. TR immediately went a bit to 73. Then 24 post-TAVI, You can see here the valve is still in place and everything looks fine, and no parabolic leak as well. LV is very thick and threatening, no parabolic leak, and this is how, just to show how thick is the ventricle, and we also are investigating here for a possible amyloid. Her gradient went considerably to 8 once the valve started opening, as well as filling her with fluid and decreasing the interventricular gradient. Her TR as well went down to 68, and the patient underwent mastectomy safely, and she's now following up in the clinic. So subaortic membrane, we don't know much about it, but we know that it's from surgical point of view, they know a lot about it. For us, from cardiac point of view, we know that it's a muscle, and it's extending usually from the annulus down the valve. Most of the patients will present with aortic regurg, and surgical therapy is considered to be definitive treatment. However, membrane can regrow in some cases for symptomatic membrane. Now, there is 2 cases actually being reported, similar cases, and we knew this at the day of the procedure. We didn't share this information because we already were scared from procedure, so we didn't share that there is only 2 cases being done similar, so we didn't have much of information to do for the procedure, but all the cases being done were done with a self-expandable valve. Thank you.